Director Garza?
Present.
Thank you. Director Kim? Director Sorrell? Director Webster-Cross?
Present.
Chair Bott?
Present.
And for the record, those directors also present. Director Harrington?
Present.
And Dr. Green is remotely present.
Yeah,
Great.
present. Thank you.
Thank you all for joining virtually in here at the meeting room. The next regular meeting of the Quality and Patient Safety Committee is scheduled for Friday, December 13th at 11:30 a.m. I'd ask if anyone's registered to provide in-person or virtual oral testimony.
We do not have any registrations. I do believe that we need a motion for Director Garza to join remotely.
Yes. I'd like to entertain a motion to allow Director Garza to remotely participate in the meeting as a voting member.
So moved.
We have a second. Motion's been made and seconded. Is there any further discussion on the motion? Hearing none, then all in favor, say aye. Hear more ayes?
Aye.
All opposed? No. All right. So we can entertain Director Garza and Dr. Green.
Dr. Green, is just Garza needs the motion.
All right. We'll go to approving appointments and reappointments. Schroeder Hospital Department Division Chairs. 2 department chair appointments and 1 division chair report being presented, reviewed by Dr. Claudia Fagan, our Chief Medical Officer with Great Stock Game.
Good morning, directors. As Director Bott mentioned, we have 3 appointments. The first one is for the chair of the Department of Surgery. Richard King has been reappointed as chair of the Department of Surgery. In this role, Dr. King is responsible for 16 clinical divisions and includes 120 surgeons and residents supporting Cook County Health patients. Dr. King earned his medical degree from the University of Illinois. He did his residency at Cook County Hospital. He did a fellowship in vascular surgery at Northwestern, and his so he practices vascular surgery. He was originally appointed as chair of surgery in May of 2008. The second reappointment is the reappointment of Dr. Mopi Akintoran as the chair of pediatrics. Dr. Akintoran has been reappointed in that role. She received her Doctor of Medicine degree from the University of Lagos and did her residency at Cook County in general pediatrics, as well as her fellowship in neonatology, and is certified by the American Board of Pediatrics in general pediatrics and neonatal perinatal medicine. In addition to her role at Cook County Health, Dr. Akintoran is the simulation training director and academic instructor and advisor, and currently serves as an associate professor in the Department of Pediatrics at Rush University College of Medicine. The third reappointment is for a division chair, Dr. Andrew Dennis. Dr. Dennis is a DO who has been reappointed as the chair of the Division of Pre-Hospital and Resuscitation within the Department of Trauma and Burn. Dr. Dennis received his medical education from Kansas City University of Medicine and Biological Sciences. He did his residency at Midwestern University College of Osteopathic Medicine. In addition to his current role at CCH, he also serves as Associate Professor of Surgery at Rush University Medical College and Chair at Midwestern University, and is Director of Medical Operations at the Cook County Sheriff's Office. He's a sworn police officer, a member and medical director of 2 Chicago regional SWAT teams, and as a trauma surgeon and law enforcement officer, Dr. Dennis is unique in his ability to handle life-threatening situations in the hospital and in the field. Those are the 3 appointments that we have for this month. I'll be happy to answer any questions.
Thank you, Dr. Fagan. Any questions? I'd like to entertain a motion to approve item 3A, the 2 proposed Georgia Hospital Department Chair reappointments and 1 proposed Georgia Hospital Division Chair reappointment. Do you have a motion?
So moved.
I'll second it, Garza.
Oh, I hear Director Garza as well. There. Okay. Motion's been made and seconded. Any further discussion on the motion? Hearing none, all in favor say aye.
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 All opposed? Ayes have it, motion carries. Thank you. We'll go to, the Sturgeon and Provident Hospital Med Staff action items that are being presented for approval. And the Sturgeon and Provident Hospital Quality Committee summaries that are presented for information. So we'll start with Dr. Huckentorn, President, Sturgeon Hospital Executive Medical Staff.
Thank you. Good morning.
Good morning.
Please be advised that the Executive Medical Staff Committee of Johnny Struger, Junior Hospital of Cook County Health, has approved the attached list of medical staff action items on October 24, 2024, for your consideration. It's a list of medical staff appointments, reappointments, and changes.
Thank you. Any questions for Dr. Huckentorn? Okay. Do you want to have, and you're presenting for, is Dr. Paul Allegretti here too? Yeah. There we go. So, we'll ask Dr. Allegretti, President of Provident Hospital Medical Executive Committee, to present a report.
Good morning, everybody. On November 8th, the Provident Medical Executive Committee approved the credentials items from Provident, and these were presented to the board here today for approval. I'm here if there's any questions or comments.
Any questions from directors? Okay. I'd like to entertain a motion to approve item 3B, the Sturgeon Hospital and Provident Hospital Medical Staff appointments, reappointments, and changes.
So moved.
Seconded.
Second.
All right, motion been made and seconded. Any further discussion on the motion? Hearing none, then all in favor say aye.
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 All opposed? All right, motion passes. Thank you, Dr. Huckentorn and Dr. Allegretti, for those reports and your work with the medical staff. All right, we'll now proceed to the minutes of the August 15, 2024 meeting, which are being presented for the committee's review and discussion if necessary. Are there any corrections that need to be made to the minutes from any of the directors? Okay. I'd like to entertain a motion to accept item 3C, the minutes of the QPS Committee Meeting of August 15, 2024.
I'll make the motion.
All right, motion made by Director Garza, seconded.
Second.
Motion made and seconded. Any further discussion on the motion? Hearing none, then all in favor say aye.
Aye.
All opposed?
Aye.
Ayes have it, motion carries. Thank you. Now we'll move to the operational excellence updates. No actions needed for these items. These are only informational. We start with
I think we're starting with the NISQIP with the.
yeah, we'll start with the
number 4.
NISQIP, which is the reports on quality and patient safety matters. And so we'll start with American College of Surgeons National Surgical Quality Improvement Program, NISQIP, reviewed by Dr. Mark Willie, Dr. Richard Keenan. Bless you.
Good morning.
Good morning.
Thanks for having me back. I think it's been 10 years, and this is a very big milestone for us. So I'm excited to talk about what we've done in that time.
Thank you.
And I know a number of you have heard this before, but I know there are new faces. So I'll go over all the details. So NISQIP, what is it? It's a nationally risk-adjusted, outcomes-based program, measures quality of our surgical care. It's built by surgeons, for surgeons, and NISQIP provides tools to the hospitals to help make informed decisions about improving our quality, our surgical quality. And there have been a number of studies that have demonstrated its effectiveness at improving surgical care, decreasing complications and costs as well. Next slide, please. So what do we get? Well, we get risk-adjusted reports that come out every 6 months. We can do on-demand reports as well. They provide conferences to help educate us about how to interpret our reports. There are best practice tools on their website. So when we identify a problem, we look toward other institutions to see what they've done, and they consolidate some of that work. They also participate in Hospital Compare, which is a CMS program that allows voluntary public reporting. And then there are audits that NISQIP does of our work to ensure that we are compliant with their standards. Next slide. So NSQIP originated in the VA in the 90s, and then the ACS received funding to implement pilot programs in some private sector hospitals. That was expanded in 2004, and ultimately we joined in 2014. Next slide. So this is just a slide demonstrating the scope of NSQIP as of our July report. There were 670 some hospitals involved in the program. Next slide. In terms of the program, it includes a number of, but not all, surgical cases that we do, general, vascular, a number of subspecialties are also represented. We can also target cases. So if there is an area that is potentially of interest, we can spend some time looking at, all types, or all cases of one type. We use clinical data. Sorry, can you go back for me, please? Thank you. That uses clinical data, not administrative data, and we assess the outcomes at 30 days after the index surgery. It's highly standardized. We have training done by NSQIP for our surgical clinical reviewers, so we can be sure that the same patients are charts are being abstracted in the same way across the program. And then NSQIP really does all the heavy lifting, and they do the advanced data analytics for us so that we can interpret our data. Next slide. In terms of the logistics of how it works, we don't have the manpower to look at every single case that we do at Stroger. So there is a systematic sampling process, and this is dictated by NSQIP. There is inclusion based on TBT codes, and then there are some exclusion criteria. So essentially, an 8-day cycle yields on average about 250 procedures, and it's an 8-day cycle so that we eliminate the bias based on the day of the week a surgeon operates. And then once the exclusion criteria are applied, which is about 30% of the cases, there's enough to fill the remaining 40 cases per cycle, which we abstract. Next slide. So our reviewers collect preoperative data, demographics, labs, surgical profile, a number of clinical variables, the complications, postoperative data to 30 days. And we can also enter custom fields if there are certain variables that we're interested in looking at ourselves. Next slide. So the content is broad. We have a number of surgical specialties that are represented, and types of complications are listed there. Next slide. Apologize for the small font, but targeted cases, we can certainly target a number of cases. We've been you'll see here momentarily, we've been looking at colectomies for a long time. Historically, throughout the program, colectomy yields a high rate of complications, so it's certainly low-hanging fruit for most institutions to work on, but there are a number of other types of surgeries that we look at, and this varies from time to time based on outcomes in a particular specialty. Next slide. Thank you, Deb. So in terms of data that are available to us, the main thing that we're focusing on is the third item there. The semi-annual reports is what I'm going to report the data on today. So these are risk-adjusted reports. So we get compared to other NSQIP hospitals. So they're modeled for a single year, and they're using their statistical methodology. We also have access to more on-demand reports. So if we're trying to look for data that aren't yet going to make it into a semi-annual report, since there is a lag toward that data, then we have access to real-time data. Next slide. So keeping it fairly simple, the statistical modeling is definitely beyond my level of math, but in terms of the results, to make it very easy for us to understand, exemplary, essentially, if you're a low statistical outlier, if you're in the first quartile, that's how you're going to be assigned, needs improvement if you're a high statistical outlier or the fourth quartile, and then as expected is if you're not a statistical outlier. And how these methods should be interpreted, there's a lot of information on the portal for the NSQIP website. We've also been to conferences, and every year the NSQIP conference, they go over their statistical methodology. Next slide. So the data I list for the projects we've done are for semi-annual reports since September of 2014. They contain a year of data. They're rolled out every 6 months. And an odds ratio is the number that I'll draw your attention to. It essentially tells you the likelihood of an outcome at our hospital compared to the average NSQIP hospital. And 1 would mean that we're working sort of at the middle of the pack. Next slide. The team here is, we couldn't do this without Blessy Varghese. She's been with us for the entirety of the program. Christine Abadilla also recently joined us. So we have 2 clinical reviewers. She'll be participating in the bariatric program. And like I said, we do 40 cases every 8 days. And I'm going to get on to some of the projects here shortly. Next slide. You've seen this slide before. Surgical site infections is certainly a very important issue for hospitals. It's obviously a problem for the patients. Patients are much more likely to be admitted after discharge if they have the SSI, 2 times more likely to stay in ICU, and 2 times more likely to die after surgery. It's very costly across the board. Next slide. So we were near 1.5 times the rate of the average NSQIP hospital when we started in 2014. This was a really heavy lift, bringing together all aspects of perioperative care, infectious disease, nursing, SPD, sterile processing department, and we began implementation around 2016, and we've had a sustained decrease in our surgical site infection rate. Since that time, our most recent semi-annual report, which came out in July, showed a rate of 1.1. It's only slightly worse than the average hospital, but certainly improved from where we started. Next slide. And then there are certain return on investment calculations that NSQIP has provided for us. And essentially, I can go on to the next slide. We had a baseline rate of 2.8%, and we decreased our rate down to 1.1% in 2017. It's been sustained. That relative change in rates is about 60%. So the number of events avoided was 96, and the cost per complication was about $2,500. So the estimated annual financial savings based on this project was about $250,000. Next slide. Another project you've heard about here is just in slow intestine after colon rectal surgery. It's a significant factor that leads to increased length of stay, can also lead to a number of other complications. Next slide. And this is one area where we've spent a lot of time, tweaking, reworking, re-engaging our stakeholders. Initially, we were 2 or higher odds ratio, so it's twice as likely to happen at our institution versus others. And we've been working with, a number of disciplines in order to decrease this over time. And so this is maybe one slide that doesn't look great, but it certainly does indicate that process improvement is a continuous process. So you can see a big spike around the time of COVID. Certainly a lot of hospital procedures were changed around that time. And so continuous involvement with our staff and re-education and re-engagement with our stakeholders is important. And I think we demonstrated that works. Next slide. Yes, and so, we were looking at other areas for improvement to try to decrease this rate. We looked at one,
Am I on the right slide?
Yeah, this is the right slide. Thanks, Deb. We looked at, fluid management during the time of surgery is certainly impactful for for decreasing this complication, and we noted a slight decrease in our compliance to that. So again, another point that we need to continually work with our people who are at the patient's bedside doing these efforts. And so we're continuing to work with them. Next slide. Yeah, I think I've restated all of this. Oh, length of stay. Yeah, so despite our prolonged intestinal recovery after surgery, we do have a slightly increased length of stay for colon surgery, but it is not statistically significantly different from the average NSQIP hospital. Next slide. And then just another return on investment calculation. Certainly this has changed over time, but based on the same types of calculation, an estimated savings of about $350,000 should be expected. Next slide. Just to give you some perspective of the cost of a participation in NSQIP for the clinical reviewer is $115,000. The NSQIP fee is $27,000, so the average, the total cost is about $140,000 annually. Next slide. Last year we came to you with an issue we picked up with thyroid surgery. So there's a nerve very close to the thyroid that can be injured or damaged during thyroid surgery. It results in airway obstruction, hoarseness, vocal weakness. So the initial data from a couple of years back showed that we are an outlier of about 2.5 odds ratio. So this is something we took to task very quickly, and we met with the thyroid surgeons and looked at how we could improve this. Next slide. Really seemed like there was some discrepancies for the definition of injury. We looked at 36 cases, 7 were assigned the occurrence. There were varying numbers across the disciplines. There's 2 different types of surgeons that do the same operation, and it didn't seem like one discipline had the occurrence more than any other. And then we looked at a lot of documentation changes. So hoarseness was not well documented in the way that NSQIP liked, and so there was some over-reporting or misclassification that we identified. Next slide. We actually ended up contacting NSQIP support about this because their model really failed to include important risk factors like cancer extent, certainly removal of the thyroid. If you have a large tumor, some surgeons actually plan to take the nerve in question. So they implemented new guidelines, incorporating some additional risk factors into their modeling. And you can see that we've, next slide, that our rate went down significantly. I'll show you a graph here shortly. So yeah, we only had 2 occurrences subsequent to this in ENT. We looked at those cases, they were all cancer cases, and then general surgery and endocrine surgery had a small number of cases. And essentially there was really no quality of care that we identified, and we thought when we got our new semi-annual report at the end of the year that the new NSQIP definition was going to was going to reflect that. Next slide. And following our identification of that issue, we demonstrated that there was a significant decrease in this rate. So there's a little break in that gap because, breaking that chart because we weren't abstracting thyroids for the entirety of that period. Again, there was a lag. So we stopped abstracting thyroids before we saw the semi-annual report that prompted us to go back to it. Next slide. So I always like to show this slide. It looks great. We started in 2014, and this shows all complications for all cases that are abstracted. And since joining the program, we've enjoyed a continued improvement over time relative to other NSQIP hospitals. And you have to keep in mind, we're not the only, we're not just getting better, but all of the other hospitals are getting better. So, we should really, I think, take a moment to be proud of the work that we've done. Next slide. So in summary, just want to remind everyone that this is a very rigorous program. It's clinical data, it's not administrative data. We are working continuously to try to improve the care here. We have ongoing projects. We've demonstrated some results. I feel like we're improving patient care, importantly, decreasing healthcare costs for the institution, and I believe it's a worthwhile investment. Thank you. I'll take any questions.
Thank you. Thanks so much for reviewing this with us. And this is, I know, a nationally recognized and publicly reported program and effort. So appreciate all the team's effort in this important work. My one question was just any high-level insights about what's been enhanced. I know you kind of reviewed it in the context of this discussion, but a couple of things that have gotten better year over year as a result of the work of NSQIP, and then see if other directors have questions.
Yeah, I think when we first started, a lot of the providers didn't really know what we were doing, and so I think just changing the culture at the institution from one of really not knowing, what we are doing and what the where our areas of improvement are. So that was globally, I would say, one of the major benefits is really changing the culture of quality for the Department of Surgery.
Director Kim.
Yeah, I have a quick question about your data collection. You mentioned you're using clinical data, not admin data, right? Does it mean that all the required data actually come in directly from EMR to feed the model, or do you have somebody actually pulling data from EMR?
Yeah, so our two clinical reviewers are back there. So Leslie's back there, Christine is back there. So they're humans that are taking data from the chart. Right now, we don't have access to like an interface to kind of do that automatically. And then there's a lot of data that patients have that isn't going to be in the chart. So they're calling patients out to 30 days to get additional information about potential complications, which is a huge area. Patients do have complications at home that we don't reflect in administrative data. So it's quite robust.
Thank you.
Thank you, Blessy and Christine, for your contributions, hard work.
I have a quick question. Will you be adding to the team so that we can extract more data to get more information?
That's above my pay grade. I think to answer that. I certainly hope so. I mean, we're rife with opportunity to continue to grow our team. So I think it would only, statistical modeling is only as good as like the numbers that you do. So the smaller number of patients that you abstract, there's a lot of statistical variability in what you're getting back. So I think it's very important if we want accurate data and modeling.
And is there plans to connect you to an electronic health record so that data abstraction is easier? Are there any thoughts?
Yeah, that's a great question. It was brought to, I think there was a pilot last year. I don't know anything more about it, but there was a pilot last year, and I don't know the outcome of that. We haven't been connected with anyone at NSQIP or Cerner to make that happen.
Thank you.
But I do want to thank Dr. Fagan and Dr. Keene. They've both been great supporters of this program from the very beginning, and I really appreciate all of that. So,
thank you, Dr. Fagan, Dr. Keene, for your leadership and support. And I know that Dr. Makaitis and Dr. Fagan have input. Yeah, go ahead.
Yeah, Director Cross, if I could quickly add.
Sure.
So we're looking at both of those areas. One through kind of how we gain economies of scale by broadening the team and ensuring that we have, additional resources available. We have a lot of pockets of people doing really wonderful things. I think as we look at scopes of what people are focusing on and bring those teams together, that we'll be able to, I think, find additional space to provide more support than we currently are in kind of the one-offs, right? The other piece is looking at not just AI, but also automating how we're looking at, data collection and all of that. So that's also being looked at concurrently. So the AI piece we're being a little bit careful with right now. Our policy is very kind of removed from any patient level data. We're doing it more on like contract reviews and that kind of stuff is where we're looking to start first. And again, right, be very careful with our PHI, right, to ensure that we're not having any, leaks or issues or anything like that. But definitely on the radar. So.
Yeah, I was just gonna mention, it's hard for me to believe it's been 10 years that we've been doing this, because I remember when we started. But yeah, the goal is to, you know, as we can, add capacity in terms of doing this. We also, I wanted to let you know that, we just, Dr. Williams has requested, and we're going to be doing a similar thing with trauma and the, data nationwide. So joining that, and looking at what we do in trauma burn as well as what we've done in surgery. So we're hoping to continue to progress down that continuum.
He has already built a roadmap to ACS Level 1 certification, so that's on the roadmap as well.
Excellent. Thank you. And I think, you know, balancing the measures that matter, also abstracting the right things that then guide improvement and intervention. Any other questions from the directors or online? Director Garza. All right. Thank you so much for the report and the work. We'll now ask Steve Kreuser, our guest from Press Ganey, to speak to us about high reliability. Good morning.
Morning.
Thank you for being here today.
Yes, thank you for having me here this morning. It's great to be able to listen in to the things you're focused on, to be part of the discussion. I have about maybe 10 minutes that I can give you a brief update on our partnership together. I'm a partner in the Press Ganey Consulting Group, and my colleagues and I are in partnership with Cook County on this high reliability and safety initiative that we've undertaken. It involves a number of training sessions for the leadership team at all the facilities. But more than that, it's about really trying to build a structure for sustainability for the long haul, to really build upon the work that was previously done here back in the 2018 and 19 timeframe. We're complete with the first session, which was an overview on high reliability principles and practices, and I hope that that's a familiar term to everybody. I'm a former naval aviator. I was a F-18 pilot for 21 years, and so that's one industry that's held up as being an HRO. I honestly never heard that term during my 21 years in the Navy. We just were focused on two things, and that's number one, safety first in all we did, and number two, mission effectiveness or high performance. And so when we think about healthcare, you're similarly focused on high performance, mission effectiveness. Hearing that great presentation on NSQIP is an example of where you're trying to excel and improve and be the best at getting better. And so when we put safety first as a qualifier to that, it helps us identify the system defects or the people issues and performing effectively in that area. But we can think about all the other verticals we're trying to improve in. So we think about the ACOG guidelines and obstetrics, or things in trauma we're trying to improve upon, or infection prevention, or even things outside of the clinical world and maintaining these terrific facilities, or getting our medical coding and billing correct, so we make sure we're financially, good stewards. And high reliability sort of cross-cuts on all those things, because it's about developing organizational mindfulness in our people to make sure we're aware of, the day-to-day situational and operational issues that are affecting our ability to do business, trying to anticipate where things can go awry. And when I say things going awry, I mean in our systems, but also in our people. And so we're working to make sure we shore up those different structures, like our huddles and how we round and how we look at our data on a regular basis and have good control loops in place to respond in a timely fashion and effective fashion. Things we do to reinforce those expectations of our frontline folks. So if we have all these guidelines we're trying to follow, for instance, in NSQIP, because again, such a great lead in here, leaders need to be aware of the people actually doing those things that are the best practices, and if they're drifting, how do we, number one, become aware of that drift in practice, and what do we do then to get folks back on track without appearing like we're being punitive in nature, because by and large, most of our folks want to do the right thing at the front line, but sometimes there's other things that are influencing their behaviors. And so high reliability is understanding what those other system level influences are. It could be cultural in nature, in terms of maybe they're getting a different message that we intend to send. The message could be they're hearing more about the production rather than the protection, goals that we want to set. So we have to be really clear as leaders that it's all about, we call it safety as a core value rather than a priority, because priorities can change from day to day, whereas core values remain the same, and they infuse everything we do like the glue that holds the fabric of the organization together. And that starts to now influence people's decisions when they're in a pinch, when they are in that moment of truth and having to make a decision. Well, do I actually scrub the hub for a full 2 minutes or whatever the guidelines say, or do I need to cut a corner so we can go a little faster, you know, turning these patients around? And in an HRO mindset, you know, at least in aviation, you know, people always say, well, you know, you may be a little focused on sticking with what's right because it's your tail on the line. We used to have a funny quip we would say as pilots, we were really focused on safety because we're the first ones at the scene of a crash. That's maybe not a good joke to share with the committee, but it is a thing that shapes your mindset. And so when we think about how we as leaders in a healthcare organization are trying to influence and shape behaviors, it's really the things we're trying to do to impart that safety as a core value kind of mindset. For the members of the committee, I think it's really important. I know this is the quality committee, and so you're all passionate about this subject, but you know, what are we doing to set the tone and to push the organization, to push the executive team, you know, forward? And we have a few thoughts on that. We'd maybe like to come back at a future time, but for right now, some simple questions to ask is, you know, how is our care and is it, you know, improving? And if it's not improving, what do we need to do as a board to help, you know, support the improvement efforts? Are there certain things that we can continue to measure in terms of process measures and outcome measures? We saw some great outcome measures here in the previous presentation. There are some broad measures in the safety and reliability space we would like you to pay attention to. The first being that serious safety event rate, which is a measure of preventable harm. I know you're looking at that, but we want to make sure that there are things we do to really elevate it in terms of its importance. If it's not decreasing, asking questions as to why it's not decreasing. I think maybe that's one thing that's led us to being back in a tight partnership. Occasionally asking about maybe specific events or having a very brief report out. These would obviously be things in the closed sessions that you'd want to talk about. We even like the idea of maybe starting with safety on the agenda as a way to message how important it is. I know there's a lot of important financial aspects and maybe logistically it's easier to do that, but it sends important messages when we say, hey, we're going to start with a very brief 2 or 3 minute, you know, safety message or safety moment, or maybe a reliability message that helps, you know, send important signals to the organization of what's important to us. Some other things to really consider or think about in this sort of march to high reliability from a process standpoint is, are we sending messages that everybody is accountable for these practices across the organization? I've been impressed by the numbers of leaders attending our sessions. We had this entire room packed on my last visit and my colleague Debbie Hunter's visit this week. And so that's really nice to see. And I think there's some ways, again, as a process measure, we're tracking to make sure all leaders attend these sessions, and there's actually pre-work and post-work expectations. We're going to try to do a little bit more in the time frame in between the sessions to make sure that we are building some good structures through our coaching efforts, mentoring, and working with the HRO implementation team to have some better rigor and sort of how, and things like how the huddles are conducted at the leadership level. We want to try to get back as much as we can, maybe in person, have some other things that we've seen that can create drift, and how the huddles at all levels, from the leadership huddles to the frontline huddles. There are certainly some unique factors. I was over at CERMAC this morning. They have a very unique patient population, and it was really neat to see how well they're doing. It actually works probably better for them to do their huddles virtually, but we'd like to maybe see the other hospitals get back in person, and we've had good conversation with the leaders of those facilities, and they're really, you know, being very engaged and in favor of some of those recommendations that we've made and are going to continue to make and work with you. There are other structural items that we're going to be putting in place. We call those HRO leader skills. You can think of it as leader standard work. One of the lessons from high reliability organizations, and I had a lot of leaders in my naval career that talked about there's a fine line between micromanagement and thorough oversight. And so what we're trying to do is not micromanage our leaders, but we're trying to give them some good structure, because that's what HROs do, is they give their leaders structure. And we think of that as, here's how we want to do these huddles, and here's who we want to lead these huddles, and here's how we want to, the things we want to talk about, and here are the ways we want to follow up on the items we hear in the huddle. We're going to come to you with some process measures that we would like you to track to make sure that those things are in place. Same thing with how we round in a very structured and purposeful manner. Same thing in terms of how we're making sure we're consistent in the application of fair and just culture. We don't want you as the board getting into the weeds on some of this stuff. We want you to stay at a high level. And so these are some of the things that we will put into a dashboard to make sure that they can lead to some maybe important questions for you to ask, again, to push the organization forward. Probably the last thing that I'll, bring up is that we have some other things that, might be helpful to you as, in terms of board awareness and education. We've got, some, different generative questions to think about, one of which is even maybe having the board put out, a board statement on safety and quality. And I'm not sure if you already have that or not, but it could, give some good food for thought and, something we'll present to you, down the line. So with that, I'll pause and see if there's any questions or comments. I don't know if any of you have been to our sessions we've had thus far. I know Dr. Makaitis has, and appreciate his leadership being out in front. But anything else you have, on your mind, I'm happy to answer.
Thank you, Steve, for that overview. I'm very encouraged and excited about this HRO journey and work that the system is driving forward. So appreciate everyone coming together to team with you and the workforce on it. Directors have any questions here online? Yeah, I was going to ask a question. But
Oh, yeah, please.
Please. Oh, okay. Given, one of the questions I had is given the population the health system serves in the community, I often think of quality and safety as two sides of the equity coin, and how to consider the through line of equity and disparities and closing gaps in the context of HRO work, because I think it's such an important opportunity and an element.
We think it's an incredibly important area to be focused on, and at Press Ganey, we've been doing a lot of work in terms of helping organizations measure. So are we segmenting our data to sort of look at the different perspectives of how care is being provided from the patient's perspective? I'm not sure how much we've thought about that, but it is something we can help, if you're not. At the heart of it all, we feel like if care is not being provided equitably to all who need it in our communities, then it truly isn't, being safe, high quality, focus, if you will. So I appreciate your comment and that you guys are thinking about that as well. We've integrated it into not just our measurement systems, but our improvement areas when we do cause analysis work, whether it be an RCA or a lesser investigation. We want to make sure that we're investigating for any sources of bias as care was being provided, whether it be conscious or unconscious bias. We've actually developed taxonomies that help us measure and sort of analyze these in different ways, because sometimes we don't see those as humans for one reason or another. We definitely are with you on that one and think it's a very important subject to be paying attention to.
Thank you, Dr. Makaitis.
Thank you, Chair Bott. So thank you, Steve. I get you kind of touched on it. We're very excited to reinvigorate this work. I know a lot of work was done pre-COVID. So relaunching this, I think, is imperative for us to focus in on. We also discussed on the importance in engaging the board and all of that as well. It comes into that discussion around kind of cascading and having that top level of the catchball be the board with our senior leadership. So thank you, Steve, and for awareness for our directors. Steve he can't be here in person, but our full board meeting on the 22nd, he'll be kind of providing a deeper dive in terms of what we've seen so far, what's coming, but again, and then the importance, of course, of the board being engaged in those discussions. So thank you again.
Yeah, I'm looking forward to, future opportunities to be in front of the full board in person. So we'll keep in close touch on when we can make that work.
Great. Thank you.
All right, thank you.
Good. I'd like to have Dr. and Amy O'Malley speak to us about the OpEx work group to provide Providence Hospital throughput update. Thank you.
Good morning again, everybody.
Good morning.
Amy O'Malley, nursing manager at Providence ED. And I think you want us to be very brief here. I know we're running out of time.
Thank you.
So we started this project on Valentine's Day, February 14th, and it was just a decrease out watches we had problems with. Two main objects of it is one of us pull to full, get the patients in the beds as soon as possible, and provider and triage, where our providers rapidly evaluate patients in triage. And we can go to the next slide. And even the next slide after that. And I think, the bottom line with our numbers, we've been very successful. Over the past 12 months, our rolling LWAT average is 5.9%. And since we started the project, it's 4.37%. But September, October have been very good. caused a lot of success, and we're on the right track.
We're going to continue and have this as a goal in 2025, but we're actually going to reduce our goal and our stretch as we move forward in 2025 and put some more measures in place. So, any questions?
Questions from the directors online? Director Garza? All right. Well, thank you for the report. We appreciate
No,
the
no
work.
sorry, no questions.
Oh, go ahead. Director Garza. Oh, no.
No questions. Just,
Got it.
it's good information. Very interesting.
Thank you. Appreciate it. So all other, information reviewed, and any questions, reach out to me or the relevant, leaders at, the health system and quality and safety on those topics. So with that, we, like to, the agenda being accepted, I can just, declare this meeting as adjourned. Thanks, everyone.